What I had to do there was breathe hard to get rid of carbon dioxide. Carbon dioxide is the neural drive to breathe. We got rid of CO2, so you should be able to hold your breath now for a lot longer than before. That's loop gain. So the obstructive sleep apnea is feeding into the central sleep apnea. For somebody to desaturate to 65%, I would suspect loop gain is kicking in here. That the individual stops breathing, but post-stopping breathing, they hyperventilate so much, they get rid of so much CO2, that now they can stop breathing for such a long time, because their drive to breathe is depleted, and now they have a stronger hypoxic effect. So, if you're desaturated to 65%, you've got a high loop gain, but you also possibly have blunted chemoreceptors, and we will speak about how can you check that with a patient. Did any of you now desaturate? How many of you desaturated this time? Can I see a show of hands? Okay, 1, 2, 3, 4. You didn't desaturate. Well, the last time, you were the only one that desaturated. So we have been able to cause you to desaturate there by virtue of the hyperventilation post-apnea, which is feeding into the degree of severity of hypoxia. You can test this during wakefulness to get an idea of what's happening during sleep. So loop gain, aside from anatomical, arguably the strongest determinant of obstructive sleep apnea is a hypersensitive ventilatory control system or elevated loop gain. If you're working with a patient, make sure you see the polysomnography. You have to check how many central apneas are they having. If they have a high degree of central apnea, and central apnea is when the brain isn't sending the signal to breathe. But the primary stimulus to breathe is carbon dioxide. If they have a lot of central sleep apnea, you could suspect that they've got a high loop gain. During sleep, your ventilatory control, and by the way during the day, is dominated by the level of CO2, but oxygen plays a lesser role. Carbon dioxide is the primary stimulus to breathe in regular, everyday breathing. Your body breathes to get rid of excess CO2. Arterial CO2 has the greatest influence, with increasing CO2 stimulating an increase in ventilatory drive. People with high loop gains have exaggerated ventilatory responses to minimal changes in carbon dioxide. How do you react to the buildup of CO2? The first test that I gave you is control pause. If you've got a low control pause of less than 25 seconds, you've got a strong ventilatory response to CO2. Any patient who is coming into you, and if they show you, if you ask them to do a simple breath hold time, the lower their breath hold time, the greater the exaggerated ventilatory response to carbon dioxide. Does that make sense? The other thing that I'm curious about is the difference between your controlled pause or comfortable pause and your maximum pause. So approximately 1/3 of OSA patients have high loop gain. So 33% of your patients will have exaggerated ventilatory responses in response to carbon dioxide. Can you change or reduce the ventilatory response to CO2? Yes. How do we do it? Breathing exercises. We change their breathing during the day to reduce loop gain during sleep. Ventilatory drive determines not only the activity of the thoracic pump muscles, but also the upper airway dilator muscles. We spoke about we need these muscles in the throat working harder. You don't want these muscles being lazy. If they're lazy, the airway collapses. But how do you get them to work harder? You need to have normal CO2. If you have an individual who stops breathing, and after they stop breathing, they hyperventilate, they get rid of too much carbon dioxide, the drive to open up the upper airway muscles is reduced. So when your breathing is all over the place, stopping, hyperventilating, stopping, hyperventilating, stopping, hyperventilating, these muscles aren't going to do the job that they're supposed to do. The upper airway is collapsible, the upper airway is susceptible to collapse when CO2 and therefore neural drive to the upper airway muscles is low. Now, what does mouth breathing do to your CO2 levels? It will tend to reduce it. So an individual who wakes up with a dry mouth in the morning, they will have poor sleep. Not only because of the increased risk of obstructive sleep apnea, and how much is it? One study showed that the AHI index will reduce by 33% just by getting the mouth closed. And by the way, 50% of patients with obstructive sleep apnea have positional sleep apnea. Their apneas will double when they sleep on their back. So 50% of your patient population coming into you, when they sleep on the back, it will double their AHI. Why? Because, of course, the tongue is going to fall into the airway. Now, back to Karen Samuel's point, I had to relearn where to position my tongue, because where is your tongue now? Do all of you have your tongue in the roof of the mouth? A very simple way that we do it, in terms of, is do the popping sound which Saruf showed you earlier on. In order to make that popping sound, where did you get your tongue? Where did you have to place your tongue? You have to place your tongue in the roof of the mouth, and that's where the tongue should be all the time. You get your tongue in the roof of the mouth, your tongue isn't falling back into the airway. So when the central respiratory output waxes and wanes, the activity of the upper airway dilated muscles varies accordingly. So that periods of low central respiratory drive are associated with low airway muscle activity, high airway resistance, and predisposition to collapse. If you are breathing hard during your sleep, you get rid of carbon dioxide, and these muscles are lazy. After arousal, most people hypervent briefly, and this basically is the diagram. So you have somebody with an obstructive sleep apnea whereby they stop breathing due to collapse of the upper airways. After they resume breathing, there's a period of catch-up time. But the catch-up breathing gets rid of too much CO2, which feeds into the next apnea, which is central. Higher loop gain defines less stable control, as a disproportionately large ventilatory response will result in a greater degree of hypopapnea. So it feeds into it. Now, can you measure it? So, I'm just going to move on just from a couple here. I spoke about, and I've mentioned this a couple of times, end-tidal CO2, significantly higher during nose than mouth breathing. It's suggested that a loss of nasal function, such as during nasal obstruction, may result in lowering of CO2, fostering apneic spells during sleep. I'm looking at carbon dioxide not just as a result of loop gain, not just a result of the hyperventilation, but in terms of the mouth breathing during sleep. How does mouth breathing have such a negative impact? And is this possibly due to the drive to breathe is reduced, and also the drive to the upper airway dilated muscles is reduced. Mouth breathing increases the dryness of the upper airway mucosal surface. Increased wall stickiness may then make the upper airway more difficult to reopen after closure. Nobody should wake up with a dry mouth in the morning. Dry mouth in the morning, trauma to the upper airways. And also you will find that people, when they switch to nose breathing, they don't have to get up to go to the bathroom as much during their sleep. If you're mouth breathing during your sleep, you're more likely to be in a lighter sleep, so you arouse out of sleep earlier. You don't necessarily have to have AHI to feel sleepy in the morning. If you have a lot of arousals during your sleep due to even the slightest negative pressure, a lower arousal threshold, it's also a problem. Increased lung volume. We have to be using the diaphragm. I'd like you to look down at your breathing, look down at your chest, look down at your tummy. What part of your breathing are you using? Are you using the upper chest, or are you using your diaphragm to breathe? If you use your diaphragm to breathe, you're improving your lung volume. If you're using your chest, you will have reduced lung volume. Increased lung volume stabilizes. This was published in The Lancet in 2014. The respiratory probably stabilizes the respiratory control system by increasing the stores of O2 and CO2. and thus buffering the blood gases from changes in ventilation. And this is what we're trying to do in terms of reducing loop gain. So, one of the exercises, how can we reduce the ventilatory response to CO2? How can you reduce loop gain? 30% of people with obstructive sleep apnea have high loop gain, and that feeds into their OSA. I'd like you to put one hand on your chest, one hand just above your navel. I'd like you to allow your shoulders to relax. And I would like you to feel the airflow as it comes in and out of your nose. I would like you to feel the slightly colder air coming into your nose and the slightly warmer air as it leaves your nose. Feel the slightly colder air as it comes into your nose and feel the slightly warmer air as it leaves your nose. As you feel your breathing, I would like you to start softening and slowing down the breath. I would like you to slow down the speed of air as it comes into your nose, and at the top of the breath, bring a total feeling of relaxation to the body to allow a relaxed breath out. I really need you to slow down the speed of air as it comes into your nose, so that your breathing now is less than what it was before you started. I want you to pay attention, bring your attention onto the breath, and really slow down the speed of air coming into your body, to the point you can feel air hunger. I'm not going to incorporate diaphragmatic breathing because it would be too much at the moment, but I want you to practice this for about 2 to 3 minutes. A few things I need you to pay attention to. One is the amount of saliva in the mouth. Number 2 is your body temperature, or the temperature of your hands. And number 3 is your state of alertness. So again, you're following the airflow as it comes into your nose, and you're following the airflow as it leaves your nose. I really need you to reduce the speed of air that comes in and out of your nose. To slow down your breath by about 30%. If you're doing it correctly, you should feel a want or a hunger for air. Some of you will have a hunger for air now. Breathe gently to maintain that hunger for air. You breathe gently to maintain the hunger for air. I'm deliberately having you reduce your breathing to increase carbon dioxide a little in the blood. You know that carbon dioxide has increased because you feel the need to breathe. The hunger for air is determined by the accumulation of carbon dioxide in the blood. I want you to slow down your breathing, to quieten your breath, to calm your breath, and to feel air hunger. Take a rest of that. Take a rest. How many of you here felt air hunger, by the way? Is there any change in the saliva of the mouth? Is it less, more, or the same? More. Is there any change in body temperature? Are you cold or warm, or the same? So what's happening there? You've just activated, some of you would feel sleepy. When we do a strong breath hold, it activates this sympathetic response. It's a stressor. But when we do slow, reduced, gentle breathing, it's activating the parasympathetic response. What we're using that exercise there for is to reduce the ventilatory response to carbon dioxide. We're deliberately increasing CO2 in the blood, and whether the theory is neuroplasticity or whether it's you're resetting the central chemoreceptors towards a higher tolerance of CO2, we don't know the theory, but we know that we are reducing the ventilatory response to CO2. If you've got a strong response to the accumulation of carbon dioxide, you will have a high loop gain that feeds in. Now with that, we also want to get diaphragmatic movements. If you're lying in bed at night, lie down, bend your knees, and start breathing gently using your diaphragm. It's true, as Dr. Christian Guilleminault, he says that people with obstructive sleep apnea, they don't have poor muscle tone of the diaphragm. Of course they don't, because they're doing strong breath holds during their sleep. And the brain is sending continuous messages to the diaphragm to breathe. The difference between an obstructive sleep apnea and a central sleep apnea. Do this for me. Take a normal breath in through your nose, normal breath out through your nose, pinch your nose, hold your nose, and sway holding your breath. And mimic the apnea. Keep holding and keep feeling the airway muscles dilating here. They're trying to open up for you. Your diaphragm is trying to move down to contract. That's an obstructive sleep apnea. Your breathing muscles are trying to bring air in. Do you feel the involuntary contractions of your diaphragm when you stop breathing there? So people would always say, we'll have highly developed diaphragms, but they don't use them, because most of them will be breathing through the mouth. So we need to restore diaphragmatic breathing. So just measuring diaphragm strength is not going to be enough, because I would expect these people to have a high inspiratory and expiratory muscle strength, but they don't use it. Now, I'm going to have you do that once more, and I want you to check your nostrils, because we said, can you decongest the nose by holding the breath? So whenever you're ready, take again a normal breath in through your nose, a normal breath out through your nose, and pinch your nose, hold your nose, and sway holding the breath. And sway holding the breath. And see how long does it take? How long can you keep holding your breath for? But I also want you to check, how is your second breath after you resume breathing? So hold your breath for as long as you can, and when you resume breathing, how is the second breath that you take? Just check your nostrils there, by the way. Check your left nostril, check your right nostril. After you did that exercise, is there any change to your nose? Does it feel freer? Your mental state, by the way, is there any change to alertness after you do a strong breath hold? Carbon dioxide has a protective mechanism during obstructive sleep apnea. When you stop breathing during your sleep, yes, it's true that your oxygen levels drop, but your CO2 levels increase. And the increase of carbon dioxide will cause a right shift of the oxyhemoglobin dissociation curve, that hemoglobin will release more oxygen to the cells. But also as you do a strong breath hold, the peripheral blood supply will constrict, and you will have increased blood flow to the brain. So carbon dioxide is very protective during OSA. This paper is very exciting. It came out just a month ago, but it's based on what we would have been seeing for about 18 years. It's the first time it's ever been studied. It's currently not possible to recognize elevated loop gain in patients. We test the hypothesis that elevated loop gain during sleep can be recognized during voluntary breath hold maneuvers during wakefulness. This is exactly what I had you do. They had 20 individuals, 10 with OSA and 10 controls. They participated in a single overnight study with voluntary breath holding maneuvers performed during wakefulness. They assessed two things. One was the maximum breath hold duration. People with high loop gain have a low breath hold time. So any of you that had a breath hold time of 10 seconds, I would really encourage you to do some work to increase it. If you have a low breath hold time, and if you suspect obstructive sleep apnea, I think it's your breathing also that needs to be addressed. And I don't want to give you 101 different things to do, but start nose breathing and start slowing down your breathing to feel that slight air hunger, to reset the breathing center towards a reduced ventilatory response of carbon dioxide. The second thing that they looked was the ventilatory responses in the first 2 breaths following 20 seconds of breath holds. So they had the individuals stop breathing for 20 seconds. And they asked the question, on their second breath, how do they breathe? Individuals who breathe hard, higher loop gain. Higher loop gain during sleep was associated with a shorter maximum breath hold duration. We have been measuring breath hold time as an index of your breathing pattern disorders. If you're less than 25 seconds, you're more likely to be upper chest breathing. You're more likely to be breathing through your mouth. You're more likely to have irregular breathing. You're more likely to breathe harder and faster. So 25 seconds is the cutoff point. Any patient or client who comes into me, I want to give them breathing exercises, just as we did, gently slowing down the breath, getting nasal breathing both during wakefulness and during sleep to improve their breath hold time, that their breathing is lighter. Hard breathing is not a good sign in anybody. The individual who is walking and are feeling excessively breathless or disproportionately breathless, that individual is going to be breathing harder during sleep. And it ties back in. What is obstructive sleep apnea? It's when the negative pressure created during inspiration exceeds the dilating force of the upper airways to keep that airway open. And that's the battle. We want to reduce the negative pressure. Can I have you slow down your breathing again? Can I have you put one hand on your chest and one hand just above your navel? I want you to really pay attention to your breath. And I want you to feel the slightly colder air as it comes into your nose and the slightly warmer air as it leaves your nose. If you find that your mind wanders a lot, you'll get so much out of this because it will hone and improve your attention. Feel the slightly colder air coming in and feel the slightly warmer air leaving your nose. As you feel your breathing, I would like you to gently soften the breath, to quieten the breath, to calm the breath. So you're paying attention to the slightly colder air coming in and the slightly warmer air leaving. And just reduce the speed of air as it enters and leaves your nostrils. Just reduce the speed of your breathing. Just reduce. Try and breathe so that you feel hardly any sensation in your nose. Try and breathe almost that you feel no air coming into your nose. Slow down the breath to the point you feel air hunger, and try and breathe gently to maintain that air hunger. This exercise will improve your blood circulation. You slow down your breathing, you breathe lightly, your blood flow is improved. You can influence 100,000 miles of blood vessels by slowing down the breath, by breathing lightly. You practice this exercise, a very simple exercise, your breath hold time increases. Your breathlessness during physical exercise reduces. You can take a rest. So, also when you breathe lightly, your nose is more likely to be more open. So we practice that breathing exercise. It improves breathing pattern disorders. After a few weeks, we bring in diaphragmatic breathing. We need the diaphragm signaling to the upper airway dilator muscles. You always have to think of these as linked. When you have a patient in your dental chair, look at their breathing when they're not paying attention to you and ask the question, are they breathing using the chest? Or are they breathing using your diaphragm, their diaphragm? You'll find the diaphragm located about 4 buttons down in a shirt. So you won't really feel it, but it's like a thin sheet of leather. If you were to look into a cadaver, it's very strong, it's very thin, and it's shaped like a dome. And it completely separates the thorax from the abdomen. So, the two things that we look at, loop gain, breath hold time. Measure the breath hold time of your patients coming in. For how long can they hold their breath? That will give you good feedback into how hard they breathe. And loop gain. Chemoreflex sensitivity, a key determinant of loop gain, can be estimated simply by measuring how long participants can voluntarily hold their breath for. This paper was the first that has been using what we've been saying for almost 20 years. We also believe that we can determine whether chemoreceptors are blunted or not by virtue of your breath hold time. Your control pause should be half your maximum pause. So I asked you to write down 2 figures. Your control pause was your comfortable breath hold time. I want to see, are you able to feel the slight accumulation of carbon dioxide in your blood? Can you feel the air hunger quite easily? Or does it take a huge, strong breath hold for you to feel the build-up of air hunger? In other words, do you feel a progressive increase in air hunger, or do you only feel the air hunger when it's extreme? So your maximum pause, if your maximum pause was 20 seconds, your control pause should be about 10. But if you find that your control pause and your maximum pause is the same, your sensitivity to the increase of CO2 is blunted. As hypothesized, we found a strong and significant inverse correlation between the maximum breath hold time and loop gain. Okay, I'm going to go quickly through it. Arousal threshold. How easy is it for you to arouse from sleep?